Hello, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. Welcome to our webinar on state Medicaid experiences with value-based payments with the Center for Healthcare Strategies and Minnesota Medicaid. Next slide. I'd like to mention a few logistical items. A copy of the slides and webinar recording will be emailed to you in the next day or so. Also, we will have time at the end of today's program to respond to your questions. I encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. Next slide. We have a lot to cover during this call. We'll start off with an overview of CAQH core work on VBP, an overview of state Medicaid agency trends in VBP from CHCS, and finally, a presentation on the Integrated Health Partnership, which is a collaboration between payers and providers from Minnesota Medicaid. After that, we'll have some time for Q&A. Next slide. I'd like to thank our guest speakers, in particular, Tricia McGinnis from the Center for Healthcare Strategies and Matt Spaan from the Minnesota Department of Human Services. Thank you so much for being with us today. And now, let's get started. I'd like to introduce our first speaker, CAQH Core Manager, Lena Geber-Marian. Lena?
Thank you, Jessica. Next slide, please. So for those of you who are joining for your first CAQH Core webinar, I just want to briefly introduce who we are and what we do. Core is an industry-wide facilitator that focuses on simple and sustainable healthcare data exchange that meets industry needs. We were named by the Secretary of HHS to be the national author for operating rule entities. What we think sets CAQH Core apart from other organizations that we are truly multi-stakeholder. Our board includes health plans, providers, vendors, and government entities. And it is this mission and vision that sort of has driven us to do this work that we'll talk about a little bit today. Next slide, please. So earlier in 2018, CAQH Core released a report that was based off several years of research in the VBP space. This research tried to look at exactly where are the gaps in the transition from fee-for-service to value-based payments and where are the largest barriers to implementation and success under value-based payment models. This report identified 5 opportunity areas that you'll see in this diagram: data quality and uniformity, interoperability, patient risk stratification, provider attribution, and quality measurement. And so CAQH Core's visions for this VBP work is a common infrastructure that drives the adoption of VBP models by reducing administrative burden, improving information exchange, and enhancing transparency. So right now, we have just concluded a VBP advisory group, which was a group of 12 industry stakeholder leaders who took a look at these opportunity areas from this report and narrowed them down to a few areas that CAQH Core could launch a subgroup off of and create operating rules. As we've historically created operating rules for the fee-for-service space, these would be our first set of operating rules that would be focused on value-based payments. Next slide, please. With this illustration, just to highlight, is that each of these 5 opportunity areas and what our operating rules will look to focus on when we launch that rule writing in the fall, it really is focused on creating that whole spectrum of payments, everywhere from fee-for-service all the way to global payments, no matter what sort of model a provider and health plan have agreed upon. These 5 opportunity areas are issues that need to be addressed and that we hope that our operating rule development will touch on. Next slide, please. And the reason why, one of the many reasons why we focus on this work now, is you can see from this graph that the number of ACOs, as just one example of a payment model, has drastically increased over a year, not just in the commercial space, but also in Medicare and slightly in Medicaid as well. So today we're going to talk a little bit about that value-based payments movement within the Medicaid space. Next slide, please. I'd like to introduce our first speaker, Tricia McGinnis. Tricia is the Senior Vice President at the Center for Healthcare Strategies, or CHCS. In this role, she oversees CHCS's broad delivery system and payment reform portfolio and directs the organization's far-reaching communications efforts and unique Medicaid leadership and capacity building programs. And with that, I'll kick it off to Tricia. Tricia?
Great. Thank you so much and welcome. Thanks for having me today for this webinar. It's a topic that is near and dear to my heart and the work that I do at CHCS. So next slide, please. So for those of you on today's webinar who may not be familiar with the Center for Healthcare Strategies, just very quickly, we are an organization that works with Medicaid agencies, health plans, and providers to develop innovative new programs and way of delivering care that will improve the health outcomes for Medicaid beneficiaries. We have a few core focus areas. I oversee our work in broad-based delivery system and payment reform, as well as our work working directly with Medicaid leaders to build their capacity for innovation and leadership. And we also work very closely to help improve models of integration for patients with complex care needs, folks with behavioral health disorders, multiple chronic conditions, substance use disorders, disabilities, and those who are dually eligible for both Medicare and Medicaid. So that's just a little bit about who we are as an organization. Next slide, please. So before I talk a little bit more specifically about key trends, I just wanted to set the stage a little bit to help folks understand the unique approaches that Medicaid takes to value-based payment. So I'll first say, and this is kind of an old adage that you hear all the time in the Medicaid space, but it's basically if you've seen one state Medicaid program, you've seen one state Medicaid program. Each Medicaid program has its own unique programs, payment methodologies, dynamics, and so each one is very different. So it's easy to kind of recognize trends, but oftentimes the devils really are in the details, and so it's particularly exciting to have a state like Minnesota on today to hear more in depth about how a particular state is tackling value-based payment. But at a high level, here I thought it'd be helpful to start with what some of the key drivers of costs are in Medicaid that really drive how Medicaid approaches value-based payment. First and foremost, the high cost, high need patients in Medicaid tend to be those with really complex care needs, including patients with severe mental health issues, substance use disorders, and chronic conditions. And the fact that oftentimes their care is poorly managed and poorly coordinated across multiple providers that they often see. And so those clearly present opportunities for improvement under VBP. Secondly, facility costs, particularly for patients that have long-term support and services needs, including developmental disabilities and physical limitations. The facility costs associated either with inpatient stays or skilled nursing facilities often are extremely high cost, whereas other alternatives such as home and community-based services that oftentimes are the preferences of patients themselves often offer a better value. The third key driver in this realm really is around frequent and avoidable emergency room use, and that occurs for multiple reasons within Medicaid patient populations, but it clearly is a key trend that we see. And then finally, and this is not unique to Medicaid, but really high cost drugs, particularly around particular conditions such as hepatitis C. Next slide, please. So some of the levers that state agencies have at their disposal for addressing those costs, value-based payment and purchasing really is just one of several. In addition to VBP, states have a lot of flexibility about how they cover and provide access to lower cost alternatives, particularly things like medication-assisted therapy, home and community-based services that are a key part of their strategy for managing their costs. They also have there's a lot of investment or support for building up provider infrastructure and capacity building so that providers, particularly those serving the safety net, are better equipped to manage patient care and do so in a more cost-effective way. Next slide. And finally, there are other kind of external drivers beyond those issues that really shape the way the different approaches that a state Medicaid agency might use in developing its VBP strategy. This list could be a lot longer than what I have on this slide, but I think these are really kind of some of the top four drivers. First and foremost, state budget constraints. Unlike a commercial plan, state Medicaid budgets don't simply increase because there are more people to cover and costs go up. Their budgets are set by the legislature and the governor, and oftentimes there are very real constraints that agencies run up against in order to keep their costs under control and kind of accountable to the taxpayer. So that's a very real dynamic. Second, federal funding and regulations. Often there are a lot of the work that we do are around new funding opportunities that the federal government has provided to states, and that has been a key driver to approaches that Medicaid has taken, as well as regulations that provide guardrails for how Medicaid can approach VBP. Clearly, the health improvement priorities within a specific state, those vary significantly state to state. One state might have a big opioid misuse issue on its hands, while other state may have maybe struggling with diabetes or chronic conditions. And those are really going to drive the different models that a state uses. And then finally, the level of uptake of Medicare models. You see in the previous slide, there's clearly a lot of activity in the Medicare space, and to the degree that providers in a given market have adopted those models, that may point a Medicaid agency to align themselves with models that already have general acceptance within the provider community. Next slide, please. So now I'm going to turn in and really describe a little bit about some of the key specific approaches that states are taking within value-based payment to give you a sense of really where states are heading. I'd say, first and foremost, states use partial capitation or per member per month payments to cover a wide range of services that they want to untether to a fee-for-service schedule. 13 states are using some form of bundled payment. 12 states have an ACO type initiative using shared savings or shared risk. And then finally, 8 states are using capitation or global payments as part of their VBP. And states may be using multiple strategies. Oftentimes, there are overlapping strategies within one state. They're typically not just using one approach. Next slide, please. So by far, the most prevalent model within Medicaid centers around a per patient per month payment to cover kind of advanced care management, care coordination, population management, disease management under kind of a patient-centered medical home model. That's by far the largest adoption point that we see thus far. And it ranges from states implementing a kind of traditional PCMH program, either using the NCQA PCMH standards or developing their own standards to tailor to their markets. In addition to PCMH models, there is a program called Medicaid Health Homes, which was established as an option for Medicaid under the Affordable Care Act. It builds on the PCMH concept, but tailors it for patients that have multiple complex physical and mental health conditions, so that they get kind of 6 core services that are really tailored to improving their health outcomes around things like care management, care coordination. The services include referrals to community and support services. And this program really has been intended to support states in addressing the most complex patients and ensuring that they have not only access to good, solid primary and specialty care, but that care is better coordinated for them. And typically that payment for the Medicaid Health Homes is paid at a rate that's substantially higher than PCMH. I think a typical range is kind of anywhere between $80 per member per month, even up to, for the most complex patients, some states have implemented around $300 per member per month. Next slide, please. Pivoting from PCMH are bundled payments, and the uptake here has been quite interesting. You've had 3 states, Arkansas, Ohio, and Tennessee, who have developed kind of robust, comprehensive episode of care programs as part of their state innovation model awards. You also have states that maybe don't have a comprehensive program, but have used bundles to deal with particular issues. Common ones in Medicaid that you see are around prenatal or maternity care, or around asthma and asthma treatment and exacerbation. But Arkansas is one example. They were really at the forefront of this. They established a program with 17 different conditions. They did this program in conjunction with a PCMH program. But you see here some early results from their program. I've listed here just a few examples of improvements that they saw for certain episodes within their program. I've also listed at the bottom some national studies around episodes. This one in particular looked at perinatal episodes, and the jury is really still out, I think, around how effective these approaches are going to be. So whereas they decreased the costs under the program, it was really as a result of changes in pricing rather than improvements in health outcomes. C-section rates, for example, did not drop. So that's, I think, in general, a big theme. We see some really promising results across a few states, but very much so the jury is really still out about what the most effective models are going to be within Medicaid. Next slide, please. The next model really is around shared savings and shared risk. Matt Spaan is going to go in much more depth about Minnesota's ACO program, but I thought it'd just be helpful to show another program. Massachusetts implemented its Medicaid ACO program recently and now has about 60% of its Medicaid beneficiaries within the program. They have a 3-tracked model, so they implemented different models within their ACO program to attract different types of providers. 2 of those models use shared savings and shared losses, while another had a global capitation payment around the total cost of care. But really across all of these models, payment is dependent upon how the ACOs perform relative to a risk-adjusted total cost of care. And additionally, the payment is contingent upon how the ACOs perform relative to a quality measurement slate. In addition, Massachusetts program also implemented 2 key features that are distinct from what you might see, for example, in Medicare. For example, they require the ACOs to partner with community-based providers of behavioral health and long-term supports and services to make sure that members who really look at those partners as their medical home are benefiting from the program as well. They also give their ACOs access to funding for non-medical services or flexible services that are meant to address patient social needs. Next slide, please. The next model really is looking at global payments, and this is a model that I think we've seen increasing uptake around, in part because provider readiness for these more advanced models is growing, albeit slowly, but it's growing. One of the first states, though, to really pioneer this model was Maryland. They received an all-payer waiver in 2014 to pay a risk-adjusted global payment to their hospitals in a way that was really consistent across Medicaid, Medicare, and commercial payers. The table that you see here shows just an example of some of the benchmarks that were set as part of that waiver that CMMI provided and how the program has actually performed. So you'll see that in terms of cost savings and hospital-acquired conditions, that the Maryland program has been quite successful relative to some pretty ambitious targets that CMMI set for them. They still, at least according to this study last year, have not seen significant changes, statistically significant changes in the 30-day readmission rate. But otherwise, there are some really promising results coming out of that approach and that program. Next slide, please. So those were 4 examples of VBP programs that states have kind of designed on their own. They've created a standardized model and then pushed that out to their providers, either through their managed care organizations or directly. But one important feature of how Medicaid approaches VBP really relates back to the fact that the majority of states now have Medicaid managed care. They contract with their managed care plans to oversee, administer, and deliver and pay for the benefits and services provided to beneficiaries. And so I wanted to explain another approach that states are increasingly using to drive VBP within Medicaid. And under this model, essentially, the state makes certain requirements, some certain VBP requirements within its contracts that it passes on to the managed care organizations. And then it's up to the managed care organization to then develop those VBP contracts in its individual relationships with provider organizations. I'll explain a little bit more about that on the next slide. So under this approach, which is quite prevalent now, I think there are approximately 20 states that are using this approach as of today with their managed care contracts. And basically what states do is they set a percentage of their provider payments that the MCOs need to tie to some type of value-based payment arrangement and are held accountable to. How they define a VBP arrangement differs by state, but a lot of them use the HCP land framework as a common framework that's familiar both with providers and MCOs, and then set a benchmark, typically one that increases over time. So for example, in 2021, Oregon is requiring that 35% of the contracts that its CCOs have with providers, 33% of the payments need to be in some form of VBP, but that increases up to 70% by 2024. And the table here lists, just to give you a feel for what those requirements look like in 2021. You have a state like Arizona that has been, it really was at the forefront of taking this kind of contracting approach to letting the managed care organizations drive uptake of VBP, and they're aiming to be at 70% by 2021. And then other states that are relatively newer to these requirements have lower rates. But in general, we're definitely seeing this because it basically delegates the decision making to the MCOs, who really are in charge of the direct contracting with the providers in these states. Next slide. And I want to conclude the models just by shedding some light on what states are doing around pharmaceuticals, since that is also a key topic. And really what they're doing here is, I would say, using value-based purchasing strategies in how they contract with pharmaceutical companies around certain drugs. And some of the emerging models include a few things really to get the pharmaceutical companies to have more skin in the game and more attention to what type of patient outcomes their drugs are providing. So one approach is a results-based contract arrangement where the pharmaceutical company has an incentive to, if actual improvements in health outcomes are associated with the drugs, then they get an incentive around that. Another focuses less on outcomes and more on drug adherence, and really giving them a financial incentive to work with providers and others to really support patients in adhering to their drug therapies. And then the final model, which has been used particularly for exceptionally high cost drugs like Sovaldi around Hep C, is a capped financing model, where essentially the state gives a pharmaceutical company who has applied competitively essentially a monopoly, but then caps the payment on a monthly basis and holds that company liable for the number of drugs that are administered, and really puts the financial risk on them to best manage the delivery of those services. Next slide, please. So I just wanted to wrap by sharing some observations on what makes this so challenging in Medicaid. I think we have definitely, in our work with states on this topic, have been genuinely impressed with the level of uptake and innovation that's going on in states, but it's not easy. Typically the safety net provider organizations are even more strapped than most provider organizations, as I'm sure this audience knows. They don't have access to capital and other financing that they need to really make investments in data sharing and analytics, upfront investments in staffing that they need to succeed under VBP model. And so that definitely limits the pace at which Medicaid can roll out VBP models. States are also struggling because it's not clear which model is the best to use in which circumstance. The evidence is not quite where we would like to make data-driven decisions on this. And then finally, there are some significant barriers around how health plan rates are set. Typically, health plans that are successful in administering VBP arrangements, they can retain some of the savings and benefits of that for 1 to 2 years, but then rates are reset after that time period. And a health plan that is really efficient and has been aggressive with VBP may see their rates drop, especially relative to another plan that has been less successful. So overcoming some of those financial disincentives is a challenge as well. So I hope that high-level information has been helpful. Look forward to your questions at the Q&A, and right now I'll just hand it over back to the moderator. So thank you.
Thank you, Tricia. That was a great overview. Really appreciate you sharing your expertise with us today. And now we are going to take a moment to get a little bit of feedback from our audience. We're going to go ahead and launch our first polling question. We're trying to get a feel for where you all are in terms of implementing various VBP payment models and strategies. So the options are, yes, we're actively implementing, yes, we're actively designing, no, and unsure. So let's go ahead. Let's see, let's give it just a few more seconds. I'd like to get a little bit of a larger percentage of our audience to weigh in. And you know, this is just kind of to get a feel for where you all are. So I think it's okay to go ahead and share the results with the audience. It's good to see that, you know, a quarter of our audience is actively implementing. A 20% or so of our audience is designing. And then there's a large percent of you that is here to learn, and hopefully you're getting what you need out of these presentations. So thank you so much for participating in this poll. We'll go ahead and close that and move on to the next slide. I'd like to introduce our next speaker, Matt Spaan, who has worked with the state of Minnesota for 10 years in health policy and payment reform. Most recently as manager for the Care Delivery and Payment Reform Unit. Since 2013, Matt has been the lead in developing and implementing the state's Medicaid Accountable Care Organization initiative, known as Integrated Health Partnerships. Welcome, Matt.
Welcome. Thank you guys so much for having invited me. And it's great to see that a good portion of the folks that are on the call do have experience with value-based purchasing. I think along with just the amazing job that Tricia always does in setting us up in any of these kinds of presentations where we're both presenting, I think a lot of the material that I'll be covering should be pretty intuitive, I think, to the audience. So I will be talking about the Minnesota's Medicaid ACO, or Accountable Care Organization product, which is Integrated Health Partnerships. But before I get there, I think it's important to kind of understand the context of Medicaid in Minnesota a little bit better. So on this first slide, what we see is that in Minnesota, we have about 1 in 5 Minnesotans, or 20% of our population, that receives their care through the Medicaid program. It's, you know, certainly not a small amount of money that's spent towards that, the $12.1 billion in annual expenditures. And so we have a lot of weight in Minnesota as a Medicaid program. Next slide. We deliver the services to our beneficiaries through a combination of both, you know, about a quarter of our population that's in Medicaid is on a pure sort of fee-for-service where the state agency, the Department of Human Services, pays the claims directly, et cetera. But more often, about 75% of our beneficiaries receive their care through managed care organizations. And we've had these MCO arrangements set up for, gosh, I think nearly 25 years, maybe 30 years now. And in Minnesota, we have 8 active managed care organizations across the state that play this role. So you kind of can see that there's some complexity in what we see within Minnesota as far as how people are receiving their Medicaid benefits and whatnot. And of that 8 managed care organizations, half of them are county-based purchasers, and the other half are sort of those commercial health plans that are active in the commercial space as well. And of course, each county may have a different combination of which MCOs are covering which beneficiaries, et cetera. Next slide. So this brings us to where the context or the environment that the Integrated Health Partnership Program comes in. I'll add a couple more complications to the Medicaid services and the Medicaid environment here in Minnesota, which is, Tricia mentioned that a couple of kinds of value-based purchasing arrangements or value-based purchasing like arrangements include the medical health homes and the PCMH. And Minnesota does have a behavioral health home program. So it's a health home program for individuals with behavioral health conditions as their chronic condition, and they receive a per member per month as well. And then we also have a PCMH program that we call healthcare homes, just to have a lot of confusing different names for things in Minnesota. And so the Integrated Health Partnership Program in many ways has to be in an environment that has some of this complex methods of payment, multiple points of negotiation by the providers with the various payers, both in the Medicaid space, the commercial space, et cetera, and a number of different programs, and just the behavioral health home and the healthcare home being just 2 of those. And it has to be done in a way that doesn't cause a lot of redundancy, that actually hopefully creates some administrative simplicity. And on top of that, we're also a state that has about half of our population living in rural counties versus metro counties. So we have a pretty big diversity in kind of the environment that our population lives in. So one of the big things that you'll hear me talk about throughout my presentation and talking about how we had to approach the Integrated Health Partnership model is flexibility. We really, I think, not only is Tricia correct that I think if you look at one value-based purchasing arrangement in a Medicaid program, you've looked at one. In many ways, if you look at one IHP, you've seen one IHP. There's quite a bit of diversity across them. But the IHP program started in 2013, and it was, the impetus for it was a lot of the same things that Tricia already mentioned that I think every state sort of faces, which is unsustainable growth of our healthcare costs, particularly within a Medicaid population that's made up of extremely complex chronic condition, people with chronic conditions, a lot of substance use disorders, a lot of social risk and social determinants in that population that make healthcare difficult to deliver and maintain. And, of course, triple aim being a big part of it, or the quadruple aim if you want to add a 4th component. All of that was sort of the impetus. And we said, hey, we know that we have a lot of diversity. We have a lot of different systems that look very differently. We don't want to be in a position of saying you have to look like this to join this new accountable care model. But we do want to establish set accountability and then let the providers with their stakeholders come to us and say, this is what we think is the right way to have this model work with an established accountability. In 2013, we started with 6 IHPs, and that covered about 100,000 Medicaid beneficiaries. And we have about 1 million to 1.2 million beneficiaries in that program. So it was a small portion. Today, as of 2019, we have 25 different IHPs across the entire state, and it's about 460,000 beneficiaries, or over 40% of our population in Medicaid is covered. Next slide. A couple of those pieces that I talked about of being that core concept or accountability is really shown on this slide here. We had to make sure that our IHP program cut across those we call Medicaid medical assistance in Minnesota, just again to be more confusing for no reason, but it had to cut across both our Medicaid program and our Minnesota Care program, which is our basic health plan. And it had to cut across both the fee-for-service and those 8 different managed care organization arrangements that we had in place. Because for us, it was really important for the provider to have something that was more unified. They negotiated directly with us, and it would cut across their nearly full Medicaid population. We did make it, it's very primary care centric, like most of the ACO models, but we knew that we had to have a lot of flexibility. And so, for example, some of our metrics may be different if we have a system that's more specialty oriented than primary care. But there had to be a defined core set of healthcare services, and that has grown over what's included in that sort of total cost of care included services across time, and for that identified population, the attribution process. And we're a state that ends up having to use the retrospective model. And participants under this sort of core accountability model can participate in one of two sort of methods. One initially was a shared savings only model, and that was intended for smaller systems, systems that were maybe made of independent physician practices, did not have a hospital, but those systems that did have multi-specialty hospitals embedded into their model would have to take both upside and downside. And again, sort of a robust quality metrics across all of those models, where there'd be some flexibility, but also some core concepts that we wanted to hold on to there. One of the most important things, though, that I think we found is this last bullet that I have on this slide. And this is that DHS we realized that Minnesota had to be a facilitative partner to our IHPs. We had to not just expect them to succeed, but help them succeed in this particular model. And one of the big ways we do that is through data analytics. We provide just a ton of claims and encounter data to them, as well as some specific reports. So next slide. So as I mentioned, we have a wide diversity of systems that can participate in this IHP program, some of which are some of our larger hospital-based systems in Minnesota, but some that are these fairly small rural clinics. And so their data analytic capacities vary greatly. And so again, when we were looking at how do we help these groups succeed, we realized we had to kind of hit the two different routes. One where there's that detailed data and you can get a giant system that has a lot of capacity and they can throw that into their HR and they can do a ton of great analytics, versus a small system where maybe the IT person is the data analyst and sometimes they're the janitor because they've got 3 people on staff that can do this work. So we created a SaaS BI tool, and I just wanted to really quickly kind of give some examples of what that looks like. This first slide that we're looking at here is basically quarterly reports that would help the IHPs get a feel for how they were performing on the total cost of care arrangement. Are you doing well? Are you doing poorly? Are you trending correctly? Or do you maybe need to re-examine some of the activities that you're taking? Next slide. Perhaps most importantly, though, from our perspective, was these different drill down reports. What these allowed the IHPs to do is more of that actual care coordination and care delivery kind of targeted approaches. And so we realized we had to create, around some of the costs, but also care coordination, utilization, what are their quality metrics looking like? And next slide. In each of these reports, they're drill down. So they can look at, an IHP could be able to filter and find out, okay, depression is the most prevalent condition within our population. And they can click on that depression measure and identify maybe the specific members. In this sort of example, it's nearly 7,000 that had that. And which of them maybe have the highest risk or have additional conditions that they're diagnosed with, so that even a smaller system would have a ready tool to be able to just execute some of the interventions that they want to do. Next slide. And I think that facilitative aspect, which to me, one of the biggest takeaways was that it allowed us to have conversations with the IHPs in a different way than we'd ever been able to as a payer. I think sometimes there can be a little bit of an antagonism between payers and providers, and I think Medicaid in Minnesota is no different at times. Sometimes it's appropriate, sometimes maybe not as much. But being able to engage with them in many ways, sort of as a peer, and saying, we have a collective problem that we want to solve, which is that our beneficiaries are not receiving the best care possible, the most well-coordinated care available. Let's tackle that together, allowed us to really grow this model. And so what this slide shows is that, we've spread pretty well across the state of Minnesota. With that 25 IHPs, there's more than 500 different locations that we're contracting with, 10,000 providers, nurse practitioners, physicians, et cetera. And we have nearly equal representation in the rural areas as we do in the metro. And so that was a really important piece for us. Next slide. We've had some successes. This is one of the things, we kind of pat ourselves on the back and I think are pretty happy with, that since 2013, it actually hit advance one more time. We've actually shown pretty good savings. One more time, I think I need you to hit forward. Great. Hot off the presses, we actually have more savings results than I initially had on this slide, and hadn't had a chance to completely change the slide and have our graphics folks update that. But, in the first 5 years of the program, 2013 to 2018, we've shown about $401 million in savings, with a portion of that being paid back to the providers. But again, that just shows that there has been some success. Now, mind you, $401 million across, it's a fairly small portion or percentage of savings over the total spend, but it is still significant. The emergency room visits and the hospital stays are one of those areas that we also monitor, and I haven't had a chance to look at the most recent data, but it seems to be trending more or less in the same way, which is we are seeing that our beneficiaries are receiving their care more often in the right place, not in the emergency room or having to be admitted through a hospital or readmitted necessarily for a condition that could be avoidable for an admit. And those are some of those sort of tangible things that we've been pretty excited about. So, yay. Next slide. Unfortunately, not everything is sort of unicorn and rainbows in Minnesota. As much as probably if you've ever been around one of us, we like to humble brag quite a bit. We have a great healthcare system. We have a lot of really healthy people in the state, but we also have some real problems still. And the current or the sort of legacy model of integrated health partnership wasn't necessarily doing a great job of addressing some of those issues. One of the big areas that I think we really struggle with is our health disparities. And this is just sort of a quick overview of some data that I pulled from County Health Rankings and Roadmaps report, but I think it gives a pretty good description of some of the disparity that we see across our healthiest versus least healthy counties, as well as a number of different racial and ethnic groups within Minnesota. Minnesota is a great place and a very healthy place to be if you're sort of a middle class or wealthy or white person, but not necessarily if you aren't. And that's one of those issues that, particularly with the Medicaid population, we realized, hey, this is something we need to address. Along with some of those other concerns that we heard from participating providers, and Tricia kind of talked about these, such as if you're a smaller system, it's really difficult to have the capital on hand to modify how you're delivering care, where if it's shared savings, you might not see the first dollar from that shared savings for another year, 2 years down the road, assuming that you even earn it in the first year. After a couple of rounds where we might rebase you and use more recent data to set your target, you start squeezing out more and more of those savings. And if you're a relatively efficient system, it becomes harder and harder to develop or to create those additional dollars to support these kinds of innovations. So those were some of the pieces that really highlighted us the need to change the model a little bit. So we launched, next slide, our IHP 2.0 model in 2018. This allowed us to maintain some of the really great successes that we had early on in the model, such as the shared savings, multiple options, lots of flexibility, having the great conversations with the IHPs to kind of push them and spur them towards more innovation and different approaches, really good, robust data. But, go back a slide. Good. But what this does allow us to do, or what this new model has allowed us to do, is to create a number of different levers. So one of the big ones that I want to highlight, and we really focused more on social determinants of health and meaningful partnerships as being one of the areas we needed to explore. So one of the big changes is that we created this population-based payment, which is a population-level payment that it represents about 1% of the total cost of care of the provider, so their total spend, and it's adjusted based on the medical risk as well as the social risk of the population, the IHP's attributed population. So that required us to do quite a bit of kind of fun projects to figure out how you even do a social risk component. Maybe that'll be a future presentation or discussion. In exchange for that, however, the IHP had to propose to us some specific interventions that were looking at health disparities, the social determinants, partnerships with community-based organizations, social service, public health. We didn't, again, with the idea that flexibility is our mantra, we didn't want to say, you have to do X, Y, Z. We wanted it to be part of a conversation where the IHP came to us with a proposal of saying, hey, substance use disorder is a huge issue in our population that we serve. We want to do these things and partner with this group. And that was something that we could then put some accountability wrapped around that in exchange for that population-based payment. We also, because we do have the multiple tracks where some systems have both upside and downside risk, for those entities, we allowed them to have more beneficial risk arrangements, meaning a greater upside risk than a downside risk, if they have what we call accountable care partnerships. And these basically would be more formalized arrangements with community organizations, mental health providers, et cetera, where there's actually written contracts in place, there's kind of skin in the game by the provider system, there's a value both to the community group that they're working with and the IHP, so that ultimately our beneficiaries are going to be gaining better services through that. And again, there's some accountability metrics wrapped around all of that, and it's all vetted. We don't necessarily, again, say this is what this has to look like, but we have to ensure that there's sort of an equal partner relationship there, and that's all part of our very heavy RFP process. And then we're also looking at different ways of increasing our data availability and timeliness. Next slide. So where are we going from here? There's a number of different things. One is we know that we're really just scratching the surface when it comes to social determinants of health and social risk information. There's we do provide to the individual IHPs some more information on their population's social risks, some of their homelessness, like housing instability and homelessness indicators, pieces around deep poverty, that type of thing, which at least gets them a perspective that they don't necessarily have in-house. But we know that there's a lot more we have to do there to identify better data sources to be able to drive better decision-making and program creation at the IHP level. We're also looking at ways, we have to evaluate whether that population-based payment is sufficient, if it's, basically as effective as it needs to be. We also need to look at those accountable care partnerships and say, hey, do we have the right ways of holding the IHPs accountable? Are we looking at the right metrics? So those are some kind of general things that we're looking at as we continue to evolve this model. And I will say that almost every year, the model is slightly different than it was the year before, which is both fun and terrorizing for us that are implementing it. But I also want to leave us on just a couple quick pieces that are sort of concrete things that we're looking at as well. So next slide. We've created, and it's not directly tied to the IHP program, but it's really driven by the IHP program, which is something we call our Encounter Alert System. So basically, it's admit, discharge, and transfer data that can be provided to our Medicaid beneficiaries on a real-time basis or largely real-time basis to address one of the concerns we've had, which is our data sets are incredibly robust, but they're also older. It might be 3 months before you find out that somebody was admitted to a hospital outside of your IHP and that you should have followed up with them. So this is one of those ways of trying to identify very concretely ways to get more timely information to the point of care and address some of the issues we have in Minnesota where that type of exchange is not quite happening as robustly as we would like. And then the next slide. The other piece we're really we're beginning some conversations with our larger integrated health partnership systems, those that have, multi-specialty integrated models, is to see if there's kind of a way of enhancing that and taking some of the lessons learned we've had within the managed care contracts and applying it to direct provider contracts that we would have with these IHP systems to have our beneficiaries enroll with them in some way, kind of for example, one of our large systems is in Alina. Maybe it would look like in Alina, someone would enroll with Alina to receive their benefits and their care. Some of that administrative activity would take place at DHS. But again, we would be putting more responsibility directly on the provider system so that they can identify better ways to support the beneficiaries that we have. It likely would include a larger partial capitation instead of that 1% PVP. Maybe it's closer to 20 to 25% in exchange for a reduced fee-for-service or reimbursement rate at the per-service level. trying to simplify some of, as I kind of started, that we have a pretty complex system in Minnesota, trying to figure out if that might create some administrative simplicities for us. So that's one of those areas that we're in the very active development of, and is, again, taken some of those lessons learned on the IHP side and the MCO side and said, hey, let's try to do some things a little bit differently and hopefully smarter. So I think that's the end of my slide deck. I think at this point I would hand it back to Jessica.
Thank you, Matt. Thank you so much for your presentation. I appreciate you sharing with us your successes, but also your challenges, because that's a more realistic picture of what we all do in these complicated healthcare situations. So thank you so much for your presentation. And now we could go to the next slide. We'll have take another pause for a polling question. We'll go ahead and launch that second polling question to get some information from our audience. Which of these topics are of most concern to you and to your organization? And these are the topics that the VBP work that CAQH Core did initially sort of bubbled up as the 5 opportunity areas that we've been working on with our stakeholders. So I'm going to give this just a few more seconds to get a little bit more feedback from all of you, and then I will share that data with all of you. So I think it's, let's go ahead and share with the audience. And clearly that data quality bubbles up to the top. I think we asked this question about a year ago when we first started working on this topic, and that topic, I think because it is so complex, it always bubbles up. And then it's interesting to see that the others are fairly balanced. Interoperability, quality measurement, and attribution are sort of fairly even there. I think when we asked this question before, interoperability was a little bit higher, and quality measure as well, but then provider attribution and patient risk a little bit lower. So this is great feedback. I really appreciate it. I think it's okay to close up the poll. And we do have a few minutes for Q&A. If you still have questions, go ahead and submit them on the questions panel. I know that we've given you a lot of information. So in the meantime, we did receive a question from Matt. So Matt, someone was interested in knowing whether Minnesota follows the APM model for provider incentives. Could you talk a little bit about that?
So we, not necessarily directly, I think we use it more as just a way of maybe some internal discussion, but we don't necessarily directly kind of try to directly align with those different categories, the 1 through 4 and each of those pieces. It does represent, it does act as a good way for us to kind of gauge whether, how similar our model might be to some of the existing models out there, and it becomes a useful way to talk about what we're trying to do. But again, given some of the just innate flexibility that we've tried to create in our model, we've found that it doesn't necessarily perfectly fit into one of those spots. And I got to imagine we're probably not the only Medicaid program that would say that, but that's certainly true for us.
That's interesting, Matt. Thank you so much. And if our audience does have questions later on, feel free to send them to us on our website, which I'll display in the next couple of slides, and we'll make sure to send those questions to our speakers. So let's go on to our next slide. As you can see here, we have a list of our upcoming webinars and presentations. There are 2 webinars here that are a collaboration with CMS, WEDI, and CAQH Core. This is hot off the press. You're the first to know about these webinars. We're going to start promoting those next week, but we're really excited to have CMS present on their administrative simplification enforcement efforts. In addition, we've got a webinar on June 20th with Security Health Plan to talk about their certification experience. And then finally, in July, we've got an attachment webinar where we're going to talk about the work we've been doing in that space. If any of you are going to HFMA, hope to see you there. We'll be doing a workshop on prior authorization on the 23rd. Next slide. So with that, I'd like to thank our presenters and our attendees for joining us. If you want to learn more about what we're doing or you have any questions, these are ways to communicate with us either via our website or our email. And I hope you have a great afternoon.